Yes, SUNNIFORECAST is an academic trial, a phase 2 trial, which, and I think we should stress at first, fully recruited. It's a first-line trial in metastatic non-clear cell renal cell carcinoma and explored the combination of ipilimumab, nivolumab, as known in the standard combination setting, 4 cycles of ipi-nivo combination, then followed by the nivo monotherapy, compared to standard of care. And standard of care was defined as a TKI monotherapy, and the minority of patients also received the TKI-IO combination. And the primary endpoint of this trial was the improvement of the overall survival rate after 12 months, which was significantly met. Overall survival rate was above 86% with the ipi-nivo treatment in this non-clear cell patient cohort in the first-line setting. Well, the trial recruited all non-clear cells, so it was not restricted just papillary chromophore. There were rare subtypes in this trial that contributed to an amount of 20% in the all-comer cohort of the really rare non-clear cell subtypes, which of course may bias the result a little bit by having all non-clear cell entities and not just pure papillary or pure chromophore. On the other hand, I think it has a readout and an outcome in these rare entities where data is lacking, and we all know that treatment is difficult in this setting. What did we learn from SUNNIFORECAST? That ipi-nivo, I mentioned that, matched the primary endpoint of OS improvement, but progression-free survival was not improved. That was not different between ipi-nivo and the standard of care. CR rates were 8% with ipi-nivo. Objective response was 20% higher if compared to the TKI monotherapy. But we also had a high rate of primary progressive disease with the ipi-nivo, but also with the standard of care treatment, just underlining that there is a need for improvement. Specific subgroups in this trial who had a more pronounced benefit were the PD-L1 positive patients, as defined by the CPS score, and the chromophore patients, interestingly. On the other hand, patients having a papillary tumor, they had not much more, well, let's say, treatment benefit by ipi-nivo over the standard of care, which I think is an interesting result. And if we put this into the current landscape, we know that we have the ipi-nivo combination, we have the TKI-IO combination, the Keynote B61 trial with the lenvatinib pembrolizumab, but also the cabozantinib nivolumab. And we know the standard of care in the clear cell setting is an IO-based combination. And what now in the non-clear cell setting? I think an IO-based combination is also the standard of care if the label allows that in your respective country. And how can we maybe differentiate these patients? We know that lamtam and also carbonivi is highly effective in the papillary subgroup of non-clear cell renal cell carcinoma in the first-line setting. Maybe there is a gap for ipi-nivo. We learned the TKI-IO combination have a lower response rate in the chromophore. The ipi-nivo were more pronounced of the benefit of OS improvement. Maybe this helps a little bit in differentiating the treatment strategy. Maybe also the discussions they had in the clear cell setting based on the data from the CheckMate 214 results. Long benefit of the OS, PFS not so pronounced, objective response well improved. If we compare that ipi-nivo compared to TKI on the clear cell setting, that they have the same discussion and the same treatment selectors for the non-clear cell cohort, but a little bit more differentiating, as I mentioned, between the respective subgroups in the non-clear cell population, like the papillary and the chromophore. So to summarize that, SUNNIFORECAST introduced ipi-nivo as a phase 2 academic trial in the landscape on the first-line treatment on non-clear cell renal cell carcinoma, and I think there's more to come to have a better readout.